pediatric fluoroscopy in the acute setting. I have no disclosures. The goals and objectives for this talk are to discuss the differences between urgent and emergent pediatric fluoroscopic studies and our turnaround time policies at the Children's Hospital of Philadelphia, and to provide alternative imaging for common fluoroscopy studies. So what is fluoroscopy good for, right? You can evaluate the airway. For stridor, you can look at diaphragmatic motion. In the GI tract, you can evaluate the upper GI, do a small bowel follow-through. You can do evaluations in the post-procedural setting. For urinary tract evaluation, VCUG, retrograde urethograms and cystograms. I mean, it's a very dynamic modality, right? And so this is what I love about fluoroscopy. But sometimes, right, your workflow is interrupted because of emergent studies. So in our definition, what is emergent? It's a study that needs to be performed within 2 hours of the order at any time, day or night. So that's our hospital policy. This means that the tech will be called in overnight or during the day on the weekend, and consulting services should be readily available to receive results. And if it's a general surgery consultation, that they be in the fluoroscopy suite if necessary. We're talking about upper GI evaluations for midgut volvulus, intussusception reduction, as well as evaluating urethral trauma. Those are the main indications for emergent fluoroscopic studies, which is different than urgent. So urgent studies should be performed within 4 to 8 hours of the order during the daytime. However, if it's ordered overnight, we do not call the tech in, and we schedule it for first thing in the morning. This is for things like esophageal retention, distal bowel obstruction, or postoperative surgical evaluation, such as tube checks or leak evals. And just to give you an idea of certain special circumstances that we divert away from fluoroscopy, if it's esophageal impaction, instead of fluoroscopy, we do sequential radiographs of the chest and abdomen following administration of oral contrast. And for bladder trauma, we actually prefer CT as the primary modality. So for upper GI evaluation, the main considerations, at least in the emergent setting, would be malrotation midgut volvulus in a patient who's, a neonate who has bilious emesis. But there are other indications that are usually more either routine or urgent. So the techniques that we use for the upper GI, you use about 100 to 400 milliliters of water-soluble contrast, right? 60% barium could be considered. If a patient has an orogastric tube, we can administer it through the tube so that we can actually have a more rapid emptying of the stomach. So usually, this is an entirely supine exam, frontal and lateral views of the esophagus, right lateral decubitus to look for retroperitoneal positioning, and a supine PA to evaluate the position of the duodenal jejunal junction, which you can see there. It usually should be just to the left of the vertebral body and kind of oriented upward at the level of the pylorus. But in 8 to 20% of patients, duodenal positioning could be a normal variant, right? So it doesn't necessarily always have to be the case, but it's extremely important that it does cross midline. If it does not, you're actually looking at malrotation or non-rotation entities. And so this is an example of a child, a 1-day-old child with bilious emesis. You can actually see here, if I can pull over the laser pointer just to make sure, there we go. And you can see here that there's contrast here in the right upper quadrant, and the third portion of the duodenum is actually not visualized, right? And you can see here that the duodenum is actually posterior in location, but the contrast here in the right upper quadrant suggests that this patient has either malrotation or volvulus. And so this was confirmed with ultrasound, and I believe the videos here are not playing. Actually, there we go. So you can see the whirlpool sign is 92% sensitive and 100% specific for midgut volvulus, and you can see here that the SMA and SMV orientation is flipped, and that you can see the swirling of the mesentery. So this was a case that was positive for midgut volvulus, and this ultrasound was done before the fluoroscopy study. So an alternative to fluoro, right, for midgut volvulus would be ultrasound. So now we've implemented a protocol at our hospital that if we identify volvulus via ultrasound, we actually divert them away from fluoroscopy. So we don't repeat the study. But it's taken the clinicians a long time to be convinced because fluoroscopy is the gold standard. Similar, we talked about food impaction a little while ago. For all food impaction studies now, we do sequential radiographs following oral contrast administration, and if we don't see the contrast column in the esophagus and we actually see it propagate into the stomach, we consider that a negative study, and we actually do not perform fluoroscopic evals for those patients. And so, if contrast reaches the stomach, there's no obstruction. If contrast is only in the esophagus, we still divert away from fluoroscopy, and so they go to endoscopy anyway. So moving on to enema. For the technique, we use water-soluble contrast at an estimation about 400 milliosm per kilogram. For infants, we use about 500 to 700. For children, we use about 700 to 1,500 milliliters, and for adults, it's much more. So we do retrograde contrast administration. It's important that we actually place the rectal tube and tape it into place to prevent leaking, so that we actually retain as much contrast as possible. And so the only real emergent indication for this would be for a patient who has intussusception. And you can see here that there's a target sign, and you can use Doppler evaluation to make sure that the wall, the intussuscepted wall, has blood flow, because that suggests viability. If there's no Doppler flow in the wall, that's more concerning, and surgery should be aware of that. And so this is an example of a 6-month-old with abdominal pain and hematochezia. Here you see on the ultrasound that characteristic findings of intussusception. Here you can actually see that there is a defect here in the right upper quadrant, right? So this mass here is actually the intussusception, and you can see that the fluid administered via enema is actually coming up against that. And as we move forward, you see that this is actually being pushed more inferiorly, and ultimately you can see that contrast actually go through the ileocecal valve, and you can see opacification of the distal ileum. And so for patients, air and liquid have similar outcomes, right? Occurrences of perforation are, there's really no difference between air or liquid, so you could use both. And for that reason, we've actually started doing more hydrostatic ultrasound-guided intussusception reduction. And you can see here the thickened ileocecal valve, and there you see the intussusception actually resolving. And so, if you do not have fluoroscopy available, you can do hydrostatic reduction using ultrasound as well, using normal saline. And so other non-emergent indications, of course, would be microcolon, especially in the neonatal period, which could be due to distal atresia, most commonly due to meconium ileus, and also for evaluation of Hirschsprungs, but those are all non-urgent indications, and they could be done within 8 hours of the study order. And this is a full-term infant. You can see here that there are filling defects within the distal ileum, and this patient very clearly has meconium ileus, given the decreased caliber of the colon. And finally, for the last emergent indication, we have retrograde urethrogram. Here in this study, you could see the penile urethra, the bulbar urethra, the external sphincter here. You can see that there's an opacity within the bulbar urethra, areas of pneumatosis, and this was a hematoma following motor vehicle trauma. And here you see the procedure is effectively to place the Foley catheter and not to inflate too much at the meatus. Once you actually reflux into the length of the urethra, to push it just past the meatus, and then to see contrast actually enter the bladder. And so there's a difference between emergent, urgent, and routine studies, right? Emergent studies should be done within 2 hours. Upper GI for malrotation, enema for intussusception, and retrograde urethrogram for urethral injury are really the 3 main emergent indications for fluoro that we call people in overnight. Urgent studies, of course, you have a bit more time, and routine studies should be scheduled as the schedule allows. And we discussed alternatives to fluoroscopy, right? So even we're moving away from fluoroscopy. You can do a lot more with ultrasound, especially with diagnosing midgut volvulus. You can also really do ultrasound-guided hydrostatic intussusception reduction as well. So I'd like to thank my colleagues who shared cases with me. This is our outpatient center at the Children's Hospital Philadelphia, and I believe we're doing really good on time. So thank you all for your attention.